Good afternoon and welcome to our Oncology Lecture Series. I am Dr. Galit Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America and the Caribbean and everyone joining us today. During this interactive presentation, you will have the ability to ask questions via the Q&A feature located at the bottom of your screen. I will be your moderator for today's lecture. This afternoon, I have the distinct pleasure of introducing Dr. Rupesh Kotecha and Dr. Reshma Mahtani. Their presentation is titled Radiotherapy Options and Systematic Therapy Options for Breast Cancer and Brain Metastasis. Dr. Kotecha is the Chief of Radiosurgery in the Radiation Oncology Department and Director of Central Nervous System Metastasis at Baptist Health Miami Cancer Institute. Dr. Kotecha is a board certified in radiation oncology. He received his undergraduate degree in psychology and medical degree from Michigan State University College of Human Medicine. He then completed his internship and residency in radiation oncology at Cleveland Clinic's Tusing Cancer Institute in Cleveland, Ohio. During his training, Dr. Kotecha received his Cleveland Clinic Gerard P. Saxton Award for Clinical Excellence and the Cleveland Clinic Educational Foundation Excellence in Teaching Award. While in training, his research focused on various cancer sites, including prostate, head and neck, breast and lung cancer, as well as primary brain tumor, brain metastasis, and benign conditions such as trigeminal neuralgia and AVMs. Dr. Kotecha treats a broad range of cancers with a specific interest and expertise in treating patients through stereotactic radiosurgery, stereotactic body radiation therapy, and proton therapy. He has received numerous awards and honors for clinical excellence and accomplishments in both research and teaching. Dr. Kotecha has been a distinguished speaker at numerous international symposiums and has published multiple book chapters, as well as dozens of articles in peer-reviewed journals, including the Journal of Clinical Oncology, International Journal of Radiation Oncology, Biology, Physics and Cancer, and Practical Radiation Oncology. He remains involved in research both at institutional and at national level. And he is the editorial contributor on the topic of brain cancer for Practice Update, an online resource for healthcare providers throughout the United States and around the world. Dr. Kotecha current research focuses on use of targeted therapies and immunotherapy together with stereotactic radiosurgery and the molecular profiles associated with radiation response in patients with brain metastasis. Dr. Mahtani is a board-certified medical oncologist and chief of breast medical oncologist at Baptist Health Miami Cancer Institute. She specializes in the treatment of clinical research of breast cancer. Dr. Mahtani received her medical training at the University of New England in Maine, has completed both her residency in internal medicine and fellowship in hematology oncology at St. Vincent's Catholic Medical Center in New York. Prior to joining Miami Cancer Institute, Dr. Mahtani served as a co-leader of the University of Miami Sylvester Cancer Center's Breast Cancer Site Disease Group, achieved the rank of Associate Professor of Medicine, and was also the Director of Community Outreach for the center. Dr. Mahtani is an active clinical researcher helping bring novel breast cancer treatments and clinical trials to patients in South Florida and beyond. She has made significant scientific and clinical practice contributions with the numerous first author publications in peer-reviewed journals. She is a nationally recognized leader in breast cancer and has presented her cancer research findings at conferences worldwide. Dr. Mahtani served as the National Committee's chair to recognize cancer clinics that offer quality care across the country. She is involved in several initiatives that enhances patient access to healthcare, as well as community collaborations for education and advocacy. She founded the Medical Education Initiative to ensure that physicians in South Florida know about the latest cancer treatments that can be provided as evidence-based care. Dr. Mahtani is a member of several professional organizations, including the American Society of Clinical Oncology and the American Cancer Society. Please join me in welcoming this phenomenal physicians, Dr. Rupesh Kotecha and Dr. Reshma Mahtani. Thank you both for your time, and thank you so very much for joining us this afternoon. The floor is yours.
Well, thank you so much for having us here today. I'm going to start with the first part of the presentation here today, and then we'll transition to Dr. Mahtani. So the topic for today, again, a dual role, is to look at the role of both radiotherapy and systemic therapy in the management of breast cancer brain metastasis. And this is designed as a paired lecture because a lot of the things that we do at our cancer center here in Miami, they're done in a multidisciplinary setting. And so hopefully this is a good visualization of what we do together. So first, these are my disclosures. Now, since I'm going first, I will discuss a little bit about the background for breast cancer brain metastasis. It's important to note that brain metastasis overall are very prevalent in our society. There's at least 170,000 to probably about 400,000 patients diagnosed each year just in the United States alone. And this accounts for the majority of tumors that we see in the brain at a ratio of about 10 to 1. About 15 to 30% of all cancer patients develop brain metastasis during the course of their systemic disease. And then if you look at autopsies, you can actually find an additional 10 to 30% of patients who have subclinical micrometastatic disease in the brain. I've highlighted here that 15% of brain metastasis come from breast cancer origin. In fact, at our cancer center, given that about 35% of our patients at our facility have breast cancer, about 20 to 25% of our brain metastasis volume is from breast cancer. So it's a little bit higher than this. Something that we've also seen is that the incidence is increasing with better systemic therapies and improved survival of our patients. Now, as we think about the key epidemiological features for brain metastasis, I've highlighted here this breast cancer column from a recent article that we put into Nature, looking at the key factors to understand breast cancer epidemiology with regards to brain metastasis. As we mentioned, about 15% of patients account for the brain metastasis population in breast cancer. That frequency does change by age, and that risk overall is low for all of our patients. So the risk is only about 5%, but there are some subpopulations of patients who have a higher propensity to develop brain metastasis, and they may develop it at different stages of their disease course. There are several disease-specific prognostic factors and now molecular prognostic features that can influence the survival of a patient when they develop brain metastasis. Now, tumor biology is really important when we're thinking about estimating a patient's survival following a diagnosis of brain metastasis. And shown here is the original diagnosis-specific GPA, which was developed from large data sets from multiple institutions. As you can see here, even in this earlier period of time when the original GPA was developed, about 10 years ago, breast cancer patients were doing better even in the higher GPA classes, but even in the lower GPA classes, their median survival was still longer than most other disease sites. What's more interesting now is that tumor biology that we think about may just not be important with regards to the primary tumor, but also as the tumor changes and as we look at profiles of metastases. So for example, here, if you look at, in this case, we put a lung tumor, but if you look at a primary breast tumor and you look at a brain metastasis, and if you look at extracranial sites of metastatic disease, there are potentially actionable mutations that can be detected in the brain metastasis that are not detected in the primary tumor or other extracranial sites of metastatic disease. In fact, we've looked at this specifically with regards to breast cancer brain metastasis, and in this systematic review of the literature, looking at paired match samples between primary tumors and brain metastasis, specifically in patients who underwent biopsy or resection, we see that there is a HER2 gain in about 10% of breast cancer brain metastasis. This is important as we think about increasing availability of agents for that specific population that will be discussed in the next lecture. If you look at a match basically between the primary tumor and the brain metastasis, again, this is looking at the biology between primary tumors. And again, this is ignoring the extracranial sites of metastatic disease. You see that there are shifts in the tumor biology that occur over time. And actually now we're looking at reprofiling these patients to see if we identify additional actionable alterations in this patient population. When we're thinking about treatment for these patients, we have to think about what are the variables that affect our management. And that includes the patient performance status, the number of brain metastases, the size, their location. Does the patient have neurologic deficits? What's the age of the patient? The primary tumor extent, their disease status and stage. Is there extracranial disease and has it progressed or not? And then increasingly important for all patients with brain metastases, but I think specific for our breast cancer patients, is patient input. I think they're having a large say in exactly what treatment that they would want. With regards to overall treatment strategies, I mean, this ranges from corticosteroids alone for patients who have very poor performance status and have very extensive intracranial disease or are not candidates for systemic therapy, standard whole brain radiation therapy, surgery with or without whole brain radiation therapy or radiosurgery, using radiosurgery first with or without addition of whole brain radiation therapy. And then this final bullet point here, systemic therapy alone, I think is going to be an increasingly used option in the breast cancer space as well. So traditionally, patients with regards to newly diagnosed brain metastasis essentially could be put into two buckets. So those who have unfavorable features, I put here some examples, for example, of poor performance status, progressive extracranial disease, or a large volume or number of extracranial metastases, and those who had favorable features. But traditionally, every patient used to receive whole brain radiation therapy. The issue that we saw with long-term follow-up of these patients is the substantial neurocognitive decline that occurs when we do conventionally fractionated whole brain radiation therapy, which occurs in about 90% of our patients. So in the modern era, essentially, we've reserved this for the most unfavorable of patients, and the favorable patients, which is essentially most of our breast cancer patients, are receiving stereotactic radiosurgery as their treatment. Now, there are many advantages to the use of primary radiosurgery for patients who have brain metastasis. I've essentially tried to summarize all of the data here to make it easier. It's an effective local therapy, and that's even for patients who have some of the more radio-resistant disease like triple-negative breast cancer brain metastasis. Can be used to target these surgically inaccessible areas of the brain, such as the brain stem. It is associated with a shorter recovery time than, for example, resection of brain metastases. It can be used for patients who have limited lesions, which is traditionally defined as 3 or 4 or fewer lesions, or even multiple brain metastases. And I'll present some of the data later on in this talk with regards to that. It can be performed in between treatment cycles, for example, patients who are receiving cytotoxic chemotherapy regimens, or even quickly prior to the initiation of treatment. It's unusual patients newly diagnosed with brain metastasis as their first presentation of breast cancer, but if they are, we can actually treat them with radiosurgery even before they get a port placed. It's safe and effective for patients who develop metachronous brain metastases, and it maintains quality of life for patients and leads to less neurocognitive deterioration. And then increasingly, what I'd like to touch on at the very end is that there may be a synergistic benefit when we're using radiosurgery with specific targeted therapies or immunotherapies. Now, radiosurgery at our institution is used for all of these indications that we have put here. I categorized them into 3 categories. The traditional role for radiosurgery is for patients who have limited disease or very few but multiple brain metastases, or those who are recurrent after prior whole brain radiation therapy. Kind of the current role is fractionation for larger brain metastases, those that used to go to surgery, staged radiosurgery for larger lesions, which we have a clinical trial for. We do preoperative radiosurgery for large resectable brain metastases, or even postoperative radiosurgery for those that are resected in large cavities. There are some newer indications that we use at our institution, for example, to boost lesions that have a poor response to whole brain radiation therapy, or to reduce the bulk of leptomeningeal disease. For example, those who are intrathecal systemic therapies, those who are candidates have to have less than 1 centimeter of volume of disease to get good penetration. And so sometimes we can reduce that bulk with radiosurgery almost as a boost. And then those who have lesions that are technically not in the brain, but within an area that we can treat with radiosurgery technologies. Now, most common questions we get with breast cancer patients is, what do we do about the patients who have multiple brain metastases? They're typically younger, they have a good performance status, they have lots of systemic therapy options. And really, if you look at the current NCCN guidelines, you can offer whole brain radiation therapy or radiosurgery. This change actually started occurring in 2014. And by 2016, essentially the committee had decided that any patient who has more than 3 lesions could be treated with whole brain radiation therapy or radiosurgery. Now, as you treat multiple lesions, you need to be able to actually see every single lesion clearly. And so at our institution, we actually implemented this bottom kind of sequence of images here. So every patient gets an MP-RAGE sequence when they're diagnosed with brain metastases, and a neuroradiologist will evaluate that. And if they're a candidate for radiosurgery, we actually use a dual sequence approach here, where we do an MP-RAGE sequence and then a new sequence called a space sequence that helps us identify very small brain metastases, especially when we're treating multiple lesions. We actually have a neuroradiologist count on both of these scans, and then we have a three-way system actually of verifying it, both with myself and a neurosurgeon, and the patient undergoes radiosurgery. Actually, this is newly published data from our institution over the last 2 years, showing that as we instituted this new sequence, especially for patients with multiple lesions, we improved the detection rates. As you can see, we saw about new lesions in 15% of our patients actually using this dual sequence approach. This actually translated to a benefit for our patients because it reduces the distant intracranial failure or the development of new lesions. Those are probably there, just not sequenced or visualized with our current MRI scans, even though the scans at our facility are actually high definition 1 millimeter slice scans. But as you can see here, those patients who receive both sequences, MP-RAGE and SPACE, have a longer time to development of new intracranial disease. Well, how many is too many to treat with radiosurgery? When we're thinking about what whole brain radiation therapy does, it treats the whole brain with radiation. It's very straightforward. Well, with our modern technologies, we can treat a lot of lesions in the brain with radiosurgery techniques. So this is actually using our Gamma Knife Icon, which is the latest version of the machine. This data that we actually just presented a couple months ago at the annual physics meeting. But if you have lesions that are less than 5 millimeters in size, I can treat 177 lesions and still give the brain less dose than I gave with whole brain radiation therapy. Now, we don't advocate for or treat that many lesions in a patient, but just to tell you where the technology is actually going. And as you see over time, as you increase the number of lesions, you increase the whole brain dose. But again, to stay under that threshold of 8 gray, which is kind of the mean dose you get with whole brain radiation therapy, you can treat a number of lesions without causing any significant brain dose. And that is what leads to neurocognitive decline in our patients. To give you an example from our facility, this is a 30-year-old who was treated at our facility. She actually had whole brain radiation therapy up front, and then she came to me for salvage treatment. And as you can see how many lesions we have treated over 5 courses of radiosurgery. So we've treated 79 lesions over 5 sessions of radiosurgery. And so essentially the whole brain only got 1 gray or 1.5 gray each fraction of radiosurgery, even though she initially had received a significant dose of radiation in the brain with whole brain radiation therapy. So my question was, she actually lived long enough to fail in every single lesion she had whole brain to. Should we have just started with radiosurgery in a patient like this? This is clinical data that we have put together on patients who have heavily been treated with radiosurgery. So this is 59 patients treated to at least 3 courses of radiosurgery, up to 8 courses. So a total of 765 brain metastases in these 59 patients. What I want to show here is actually these are patient reported quality of life metrics. These are patient filled out, not physician, nurse metrics. And you can see that we can actually maintain a patient's quality of life over time. And that's even if I separate the patients who have 3 to 4 courses of radiosurgery or even more than 4 courses of radiosurgery. So this is what we're doing to really push the envelope for what we can do with radiosurgery technology. Now, although this is the picture I showed you before of where we stand with regards to treatment of brain metastases, it's a little bit of a lie here because really, I think the most favorable of patients are actually going to start receiving systemic therapy alone or molecularly targeted agents. And really what we need to figure out is this middle box here, which is radiosurgery and combining systemic therapy for the majority of patients with brain metastasis who sit kind of in this in-between box. It is important to note overall, though, that the FDA-approved genome-derived therapies that are available on the market right now, although they're very exciting, they do help only a minority of patients with advanced cancer, and most of these actually exclude patients with brain metastases. When we're thinking about the penetration of these agents and their response rates in the brain, you can see that the drugs that we think about in the breast cancer space that Dr. Mahtani will go over kind of fit into these three buckets that we put here in this paper, essentially into those mostly that have a less than 25 to 50% CNS response rate. And so at our facility, mostly we combine these agents with radiosurgery rather than using them alone for brain metastases. But I think that area is evolving. So for the final part of my talk, I just wanted to discuss how we combine some of these agents with radiosurgery. So I'll pick out kind of two of these agents here. This is just a graph for how long we break drugs between radiosurgery based on their perceived risk of combining these agents. So we'll give some examples here in the literature. Overall, we don't actually break a lot of systemic therapies with radiosurgery. We had done this previous large study of 1,600 plus patients, almost 3,000 brain metastases, looking at radiosurgery versus radiosurgery and systemic therapy at the same time. And there was no increased risk of radiation necrosis. But there are some subsets in which we can really have a benefit if we combine their therapies. And so this is specifically looking at our breast cancer population. So we have over 500 patients, 3,000 brain metastases. I'm going to focus on just the radiosurgery patients, which is a subset of 200 plus patients with 864 lesions. If you look at this, this is the response or the failure rates after radiosurgery. These actually mirror what you'd think about if you had a lumpectomy and adjuvant radiation therapy for breast cancer. In the pre-Herceptin era, the HER2 positive population had the highest risk of a failure. And we actually saw this in the breast cancer space as well. So these patients actually have the highest rate of local failure, followed essentially by the triple negative or the luminal B. This is graphed out with the Kaplan-Meier curve, so you can see that HER2 population, that increased risk over time. More recently, we've seen that if we look at patients who are treated with or without a concurrent HER2 EGFR TKI, which is lapatinib in this case, we could reduce the local failure rate essentially by a third if this is timed at the time of radiosurgery. We see a modest, small reduction in distant intracranial failure. But at least this is evidence that we should potentially combine these therapies. This is obviously exaggerated a little bit in this Kaplan-Meier curve to see that reduction. A follow-up study that we did showed that this really only helps the smaller brain metastases. So this is tumor volume essentially in these three kind of circles here. And the green circles show where the combining lapatinib plus radiosurgery actually led to a additive or potentially synergistic benefit. And you can see that only for the lesions that are less than the 75th percentile. For the very large lesions, those lesions do not get an additive benefit with the combined therapy. They probably need more enhanced techniques, such as, for example, surgery in those cases to improve the local control rate. Now, recently, the RTG actually ran a trial, RTG 1119, which randomized patients to radiation, started with whole brain, but then went to radiosurgery, plus or minus lapatinib. This is based on encouraging data, as I'd shown you from our institution. And this was a randomized study that was completed, has not been published yet, but I think it is accepted. Overall, this study was negative. It did not improve the primary endpoint for this study, which was 12-week complete response rate. As you can see here, this was about 60% in either arm at at the overall response rate at 12 weeks, of which the complete response rate was essentially less than 5%. It did not meet that primary endpoint, but there are a lot of caveats to this. I mean, it did improve the 4-week response rate. And the problem is this study opened, imagine when I was in medical school, I did all of my training, I completed residency, I then became an attending, opened this trial after a year, and it was able to accrue patients to this study. So this study ran for such a long period of time that in the breast cancer space, these targeted drugs actually became available. And so patients could receive these treatments as off study essentially. And so they could continue receiving this. And so therefore, I think this trial was technically negative, but I don't think actually answered the question that we were looking for. So we still at our facility offer radiosurgery and concurrent targeted therapy, in this case, lapatinib. Now, the one caveat I would give you is the potential risk of radiation necrosis in patients who receive radiosurgery and TDM1 agents. There was an initial retrospective review of 12 patients who were treated with radiosurgery and TDM1 agents, and the radiation necrosis risk was 50% in the concurrent group and almost 30% in the sequential group. You can see an example here of a patient with a small left temporal lobe lesion. expansive hematoma completely resected, and this is just delayed radiation necrosis. There have been a couple of recent reports that just came out in the last 2 weeks that also confirm this elevated risk. And finally, immunotherapy is coming on the scene for breast cancer. And so, this is an exciting area for us, given that radiation therapy combined with immunotherapy can not only enhance the local tumor response, but it can also potentially lead to a strong abscopal effect. We looked at our data of 150 patients treated to over 1,000 brain metastases, and we looked at those who received radiosurgery with or without immediate immune checkpoint inhibitor therapy, and we saw increased rate of complete response as well as any response with immunotherapy and radiosurgery. So I think this is an exciting area as immunotherapy becomes used in the breast cancer space. I'll leave you with some of the ongoing targeted therapy trials and immunotherapy trials combining radiosurgery and a variety of systemic therapy agents for breast cancer brain metastases. And we'll move on to the second.
Thank you. That was great. Let me just pull up my presentation here. You can see okay?
Yep.
Okay, great. All right. So that was a wonderful review. I learned a lot. Dr. Kotecha is great in almost doing my job for me, because there was a lot of systemic therapy information that was great that he included. So we will shift focus a little and talk a little bit deeper about the systemic therapy options for breast cancer patients with brain metastases. And these are my disclosures. Okay. So as we just heard, breast cancer, brain metastases in breast cancer patients, this is an area that is still an unmet need. There's a treatment challenge here. Breast cancer is the second most common cause of brain metastases after lung cancer. And one of the issues that we've had, which is sort of, speaks to the progress that we've made in treating breast cancer patients, is that they're living longer, and that's a good thing. But many of our systemic therapies don't penetrate into the CNS, and this extended survival that has accompanied metastatic breast cancer treatment advances have given these patients more time to develop brain metastases, which we know are ultimately the cause of death for patients with metastatic disease who develop CNS events. Importantly, these metastases can occur even in patients who have disease that's controlled systemically or who are not progressing on current treatment. And as Dr. Kotecha pointed out, despite this high area of unmet need, these are the very patients that are often excluded from clinical trials. Many of these trials allow patients on that have stable treated brain metastases, but those with active brain metastases are routinely excluded, and those with leptomeningeal disease are very often excluded as well. So certainly we have room for improvement. Now, one of the most common presenting symptoms of brain metastases is headache, but of course we all know that patients can present with seizures, altered mental status, and an MRI is actually recommended for the diagnosis of brain mets, but CT can be used for those who cannot have MRI. And importantly, an increasing number of brain metastases are found incidentally, and many patients are actually neurologically asymptomatic, which brings up the discussion of, screening brain MRIs and should we be doing them or not. And I have a slide later that addresses that, and I'll sort of editorialize, how I feel about screening brain MRIs as well as we get to that point in the talk. So there are multiple risk factors for the development of brain metastases in patients with metastatic breast cancer, and some of them are included here. The most important would be HER2 positivity or overexpression, which Dr. Kotecha also went through some of this information, but patients with high histologic grade tumors, multiple lymph nodes involved, many non-brain metastatic sites, triple negative breast cancer, larger tumors, and younger age. So we know that HER2 positivity is one of the greatest risk factors for brain metastases in breast cancer. And here you see a breakdown in a bar graph of the frequency of brain metastases across breast cancer subtypes. And you see the dark gray bar are the hormone receptor negative HER2 positive patients where the incidence is the highest. And also the blue bar would be the hormone receptor positive HER2 positive breast cancer patients, triple negative as well at a pretty high rate when looking at the total entirety of patients with brain metastases. Now, specifically in terms of HER2 positivity and why this causes an increased risk of brain metastases, it may be due to signaling between HER2 and its family members, specifically EGFR and HER3, which have themselves been found to be drivers of breast cancer brain metastases. So importantly, there are patients that have brain metastases in HER2 positive disease who are otherwise responding to treatment. And here you see results of this cohort study of about 77 patients treated with first-line therapy where CNS metastases were diagnosed. And here we saw 24 patients were still responding or had achieved stable disease while receiving treatment. The pie chart breaks down the status of extracranial disease at first brain metastases. And you see again, 40% stable or responding extracranially and 32% having no extracranial disease at all. Now, as we look at breast cancer brain metastases and outcome by tumor biology subtypes starting on the right, you see the probability of overall survival on the x-axis months since diagnosis of brain metastases. And where we have the most work to do, I would say, is in the triple negative space. For HER2 positive breast cancer patients, we have made significant progress. And as I'll show you when we get more into the discussion on the specific systemic therapies, we've finally started to make some inroads in treating patients with HER2 positive disease with targeted therapies that are starting to get into the CNS. But for triple negative patients, we have, as you can see, a lot of work to do. The green line is then the hormone receptor positive HER2 negative patients, and then you see it broken down by the triple positive and HER2 positive hormone receptor negative patients. And as we look further into the cause of death in patients who develop brain metastases, this study illustrates that many of these patients are actually dying of their CNS disease. So here you see in a study of 218 patients with HER2 positive breast cancer and CNS mets, 70% of patients had died within 2 years of CNS metastases or the diagnosis of CNS mets. And you see the cause of death broken down in this pie chart: distant metastases, meaning mainly visceral disease, likely both in 9% and unspecified in the rest. So I had touched upon this topic of screening guidelines for patients with brain metastases, and ASCO recommendations actually include that if a patient does not have a known history or symptoms of brain mets, routine surveillance with brain MRI should not be performed, but clinicians should have a low threshold for performing diagnostic brain MRI testing in the setting of any neurological symptoms. And NCCN guidelines indicate that once brain metastases are diagnosed, MRI should be conducted every 2 to 3 months for 1 to 2 years, then every 4 to 6 months indefinitely. Of course, these recommendations have to be individualized. I would just say that I think my feeling on this is that these guidelines were issued in the era prior to our availability of systemic therapies that really got into the CNS. And in my practice, although again, not supported by the guidelines, in a patient who is at extremely high risk, someone who has HER2 positive disease with a larger tumor and a heavy burden of systemic disease, I may consider doing a screening brain MRI, although it's not recommended by guidelines. And certainly I would have a very low threshold if a patient had any symptoms, even subtle symptoms, to do the brain imaging. Now, in terms of our systemic therapy options, we have them broken down here. This is not an exhaustive list, but for HER2 positive breast cancer, there are several targeted therapies that target HER2. In fact, there are now 8 targeted HER2 directed therapies approved for HER2 positive breast cancer. And looking at some of these treatments, the one that I am going to focus a bit on is the last one that was added in 2020, the tucatinib, trastuzumab, capecitabine regimen, which is approved after 1 line of therapy in the metastatic setting, so 2nd line and beyond for patients with HER2 positive metastatic disease. And then in the HER2 negative space, platinum, etoposide, combination chemo, high dose methotrexate, to name a few. Now, specifically looking at patients with brain metastases, for the hormone receptor positive HER2 negative patients, there are a variety of options. Usually we give patients endocrine therapy until they become endocrine refractory, although we know these drugs don't generally get into the brain. There are smaller drugs like capecitabine and even platinum therapy where we've seen some responses. Dr. Kotecha pointed out some of the data that we have with CDK4/6 inhibitors, specifically with abemaciclib and ribociclib, which we know do have some CNS penetration. And then for the triple negative patients, you see the addition also of PARP inhibitors with, of course, germline BRCA mutation. Patients can be hormone receptor positive as well, but I'll show you some data on the efficacy of PARP inhibitors and certainly some data for immunotherapy, as was also already alluded to. But it's important to recognize that none of these therapies are FDA approved specifically for the treatment of breast cancer brain metastases. And you do see capecitabine, platinum, and etoposide listed in clinical guidelines. And I'll just reiterate what Dr. Kotecha mentioned about the genomic sequencing that we're now doing on these brain metastases and recognizing that they may not always have the same mutations that are present in the systemic visceral disease or elsewhere the disease. And so a lot of the trials that are ongoing now are looking to target the actual mutations that are present and are different in the brain metastases. So this is one study. I'm going to go through some of the data for HER2 positive disease, for ER positive, and then for triple negative. This is a study at my prior institution that I actually participated on. And I put several patients on the Patricia trial. So here you see that this was a study for patients that had CNS metastases, HER2 positive disease. Trastuzumab has no maximum tolerated dose, so one could push the dose of trastuzumab to overcome any potential PK barrier. And that's shown here on the slide and on the left, where you see radio-labeled trastuzumab getting into the brain. And in this trial, it was actually high dose trastuzumab and pertuzumab for patients who had received radiotherapy in the past for CNS metastases. I had a couple patients that we put on this trial. I remember vividly, I had one patient who had inflammatory breast cancer and had responded really well to neoadjuvant therapy, had a complete pathologic response, and then developed brain metastases, and she was put on the trial and was a responder. So it was gratifying to see, but the duration of response is very minimal here, 4.6 months. Clinical benefit rate shown at the bottom at 4 and 6 months was 68% and 51% respectively. So as we look at the drugs that do have the ability to penetrate the CNS, it's understood that smaller molecules with the smaller molecular weight have the potential to penetrate an intact and a disrupted blood-brain barrier. This is a busy slide, but basically it makes the point that compounds that have lipid solubility and a molecular weight around 400 to 600 Daltons, and a lower participation in hydrogen bonding may be able to penetrate an intact blood-brain barrier. And here you see some data that shows that tyrosine kinase inhibitors have a 7 to 9-fold greater concentration in brain metastases than in surrounding tissue. And this kind of gives us the support for combining these drugs with other agents like capecitabine that we know can also get into the CNS. So this preclinical work was actually the basis for which we have the data for the tucatinib, trastuzumab, and capecitabine combination. This was the HER2 CLIMB trial. This was a randomized phase 2 study with the power of a phase 3 trial. And what was really notable here is that the population of patients that were permitted on this study was unique in that patients that had brain metastases were permitted, but not just stable brain metastases. Patients with active brain metastases were also permitted on. And so if a patient had a brain met that was 2 centimeters or less, not requiring immediate local therapy, they were able to go on this trial without any radiation given to the brain metastases. And of course, patients without brain mets were also permitted on. All of these patients had received our prior standard treatments, including pertuzumab, trastuzumab, and TDM1, and they were randomized 2-to-1 to capecitabine, trastuzumab, and tucatinib versus capecitabine, trastuzumab, and placebo, with the primary endpoint being progression-free survival. The kinome map on the bottom just gives you a bit of the differences in the tyrosine kinase inhibitors, tucatinib, neratinib, and lapatinib, and makes the point that tucatinib is highly selective for HER2, and this is thought to give it a bit of a better profile in terms of some of the EGFR mediated side effects that we see with some of the other agents like diarrhea and rash. And so here we see multiple data points from this trial. I'll first just point out the overall survival benefit shown on the upper right-hand side in patients with brain metastases, on the lower left-hand side in patients with active brain metastases, the 2.4% higher fold intracranial response rate seen, and on the lower right, the new brain lesion-free survival, which was also longer in patients who received tucatinib. There were updated results presented from the HER2 CLIMB study looking at specifically progression in the CNS, so that CNS progression-free survival broken down by patients with active brain mets and stable. And you see the differences in PFS, 9.6 versus 4 months and 13.9 versus 5.6 months. Again, I had mentioned earlier that patients who had active brain metastases were permitted on this trial, and there was an overall survival benefit in those patients. So this triplet combination is very active regimen for patients with active and stable brain metastases. I'll just point out the toxicity profile of this drug includes diarrhea, palmar-plantar erythrodysesthesia, which we know is a common side effect of capecitabine, some LFT abnormalities, but many of these patients didn't have to go off for the LFT issues. So this is a very effective combination. And also, interestingly, as I pointed out earlier, patients with leptomeningeal disease are a particularly difficult subset of patients with brain metastases. And here we do have some data from a phase 2 single-arm study of patients with HER2 positive breast cancer and newly diagnosed leptomeningeal disease with this combination of tucatinib, trastuzumab, and capecitabine. And here you see the median overall survival time of 10 months, which doesn't sound like a lot, but it compares quite favorably to the historical control of 4 to 5 months and represents a clinically meaningful difference in overall survival for these patients. Again, patients that are not routinely evaluated in clinical trials. And before we go off of the HER2 positive space, I'll just point out the results of the Destiny Breast 03 trial. This was a very important study because trastuzumab deruxtecan, which is an antibody drug conjugate, was routinely used in third line or later disease until the results of this trial, which compared it head to head against what had been our standard second line therapy, TDM1. There were patients in this trial that had brain metastases, about 80 patients total. And again, not the same as the HER2 CLIMB study in that this trial did not permit patients on who had active brain mets. They had to have stable treated brain metastases to go on. But just looking at this trial in terms of the breast cancer subgroup analyses of those who had brain metastases, you see the progression-free survival Kaplan-Meier curves for patients with and without brain metastases shown on the left. The hazard ratio is very similar, and you see the intracranial responses. So this on the right in the waterfall plot, which are pretty impressive when you look at the almost 28% complete response rate seen with TDXD, which really challenges the paradigm that these larger antibody drug conjugates do not penetrate the CNS. Again, small numbers and certainly not as powerful data, in my opinion, as the HER2 CLIMB trial, but very interesting that we're seeing these ADCs now having some response in the brain. And moving on to the ER positive patients, for these patients, we know, although it's the most common breast cancer subtype, the incidence of brain mets is lowest in this subtype. And CDK4/6 inhibitors and endocrine therapy are routinely used and exhausted prior to using chemotherapy. Many of these patients develop brain mets very late in their disease course, but some of them do develop brain mets at a time where it may be still appropriate to treat them with hormonal therapy and a CDK inhibitor. Unfortunately, there are data with these drugs, specifically Abema and Ribo, that there are some responses, although the intracranial response rate is about 5%. The clinical benefit rate is 25%. And again, an area that needs more options. Here, just shown again, are some of the efficacy data with abemaciclib in patients with hormone receptor positive HER2 negative breast cancer with the median intracranial PFS of about 4.9 months. So not something that we see very commonly, but for those patients that do develop brain mets and are ER positive, we do have some therapy options. Certainly we need more. And this drug has also been looked at in patients with leptomeningeal disease. And you see here the breakdown of a very small number, 7 patients in terms of CNS imaging response for those with leptomeningeal, parenchymal, and extracranial. The median OS here was 8.4 months. Again, just speaking to the fact that abemaciclib does get into the brain. So what about PARP inhibitors? There are 2 available PARP inhibitors for patients with germline BRCA mutations, talazoparib and olaparib. The Embraca trial looked at talazoparib versus treatment of physician's choice in patients with germline BRCA mutation. And here you see the progression-free survival in patients with CNS mets, only about 63 patients. The median PFS for the total study population is shown at the bottom. And here you see some difference, 5.7 versus 1.6 months in those 60 patients that had talazoparib. And so there is another PARP inhibitor, niraparib, that has shown some preclinical data in terms of crossing the blood-brain barrier. And in the interest of time, I'll just show you this slide very quickly. But again, there is some rationale to consider that PARP inhibitors may also get into the CNS. And then looking at patients who have triple negative breast cancer, where we do have an FDA approval for pembrolizumab in the first line setting. Here there are results that I'll show you from a multi-cohort phase 2 study in patients that had leptomeningeal carcinomatosis and variety of different tumor types here treated with pembrolizumab. primary endpoint, overall survival at 3 months. And here we saw that the study achieved the primary endpoint. I was very interested to see the data that Dr. Kotecha showed us with IO therapy and radiation. And I think that there is a rationale to use our systemic therapies with radiation in the appropriately selected individual. And so in conclusion, and I can leave us about 10 minutes here for some questions. Breast cancer brain metastases remains a treatment challenge. HER2 positive disease is associated with the highest increased risk of CNS Mets, which we know once they develop negatively impact survival. The blood-brain barrier is an important consideration in the treatment of breast cancer brain metastases. There's been some progress in the development of systemic therapies, but we need to do better, especially for our patients that have leptomeningeal disease, and there should be a low threshold for neurological imaging as some patients are completely asymptomatic. And with that, I will stop sharing my slides, and I gave us 10 minutes. Oh, I think you're on mute, Dr. Hakim.
I was. Thank you so very much. As a matter of fact, I was thanking you and Dr. Kotecha for the phenomenal presentation. It's remarkable what you guys have achieved in the past 10 years, especially in regards to the treatment of brain metastases. The last slide, the one before last, in regards to the pembrolizumab, that shows that the amount of time that you have gained in while treating this patient for at least improving her quality of life is simply remarkable. We're looking forward to really seeing results and new medications coming, obviously, to help us with these patients. Dr. Kotecha, why don't we go ahead and engage you both in any last thoughts or comments that you might have in regards to what you're excited about for the future in regards to both breast as well as brain metastasis and other conditions that you guys are treating currently?
Sure. So I'm excited about a couple of areas. So I think, the patients that we didn't really touch on the most here, which are the patients who have the most extensive ventricular disease, which is leptomeningeal disease, we're actually starting to transition and offer them a radiation therapy option that's not whole brain radiation therapy. Obviously, they're not radiosurgery candidates, but now we're actually transitioning to offering them proton craniospinal irradiation. So this is something, especially in this space for breast cancer patients, for example, those who have lesions that undergo resection, especially in the posterior fossa, those who have HER2 amplification, those are high risk for developing leptomeningeal disease afterwards. And our treatment options were limited from a radiotherapy standpoint for these patients. We did have some systemic therapies, and there are actually more on the market for these patients. But in general, we're actually now transitioning towards offering proton craniospinal irradiation. There was a clinical trial that actually was led at MSK and supposed to actually be at our institution as well, randomizing patients to whole brain radiation therapy versus proton craniospinal irradiation. That trial was actually closed early by the DSMC, even before we could open that at our institution, because it was a positive study. The primary endpoint for that was actually central nervous system progression-free survival, but it's actually positive for overall survival. And that study, the long-term report, we're still waiting on, but the early report was actually published in JCO and has activated a number of institutions to start offering this. That just got done at ASCO, so that's about 3 months ago, maybe 3.5 months ago. We've treated already 8 patients at our facility that have come from all over the state for this treatment. And we're actually collecting a large multi-institutional registry across the country to actually collect these outcomes at all the proton therapy centers, number one. And we actually have a trial being designed with the NRG to actually test this concept, powered for overall survival. So that's what I'm excited about in this space.
We have a question from Danielle, and it says, which is the incidence of brain cancer metastasis with HER2 positive in patients who have received therapy with carboplatin and docetaxel?
Yeah, so I think what that person is probably getting at is patients who receive treatment in the early stage setting often receive carboplatin and docetaxel in combination with trastuzumab and pertuzumab. we're moving more and more towards using neoadjuvant therapy in HER2 positive disease in patients in the early stage setting. The traditional indications used to be in tumors that were 2 centimeters or greater or lymph node positive disease. But now with the availability of the Catherine trial, and just to recap, the Catherine trial was a study where patients who had residual disease post receipt of neoadjuvant therapy, mainly with that cocktail that I just mentioned, TCHP, they were randomized to receive TDM1 versus trastuzumab in the adjuvant setting. We know those patients with residual disease have a considerably high risk of relapse, and the hazard ratio was 0.5, meaning there was a 50% reduction in the risk of recurrence with the use of TDM1. And so in that situation now, we're moving more and more to considering HER2 positive breast cancer patients, even with tumors as small as 1.5 centimeters, lymph node negative, to receive neoadjuvant therapy. What was really because the response and the ability to tailor our treatment in the adjuvant setting and receiving TDM1 as opposed to trastuzumab, from the Catherine data, that information that we get and our ability to tailor the response afterwards is crucial. And in that trial, I'll just point out, as we're circling back to this discussion on brain metastases, there were patients that had residual disease and had received Herceptin, and their relapses were like 12% of patients, and they were all still mainly relapsing in the CNS, which again points to the fact that TDM1, even our best drug in reducing systemic metastases, does not really get into the CNS. And so that's the basis upon which studies that are now accruing and are looking at TDM1 in combination with tyrosine kinase inhibitors in the adjuvant setting, with the thinking that if these patients are going to relapse, we need to give them something that gets into the CNS.
Dr. Kotecha, in regards to what you mentioned with the proton therapy for breast cancer victims, how is there already a data that will actually demonstrate the efficacy of proton therapy, especially for left breast cancer patients? Do we have a data in the last years as of where we are in regards to the efficacy and in this type of treatment?
Yeah, so that's transitioning, moving from the brain metastasis space to patients who have locally advanced disease. Our breast team actually uses a methodology to evaluate patients for radiation technologies, including proton therapy. And what they're looking at is both the heart metrics, such as the mean dose to the heart, but also the volume of the heart receiving certain doses, but also to the LAD. So that's contoured or delineated for every single breast cancer patient who's receiving nodal irradiation or left-sided irradiation for all of our patients. And then the decision is made to transition from, for example, traditional photon techniques to potentially putting the patient prone, or potentially using a deep inspiration breath hold to move the heart away from the breast, or then to transition to proton therapy. Now, the easiest one is to do proton therapy because you can treat the patient with free breathing. And we know even for those more straightforward cases, it still is going to result in a lower heart dose and LAD dose. But those are the metrics that our breast cancer team uses to triage patients.
We know that both of you, obviously, but we know that Dr. Kotecha is involved in several research studies, and very progressive, as I might say. It's kind of like cyber thinking, really. What are you most excited about in the future of radiation oncology? What is it that you have heard or looking into actually implementing in our patients?
So we have, new clinical trials to combine some of these systemic therapy agents with radiosurgery to improve our response rates and also to improve the durability of response without increasing the risk of radiation necrosis. And that's what we're working on right now. We actually have a new clinical trial that is in the design process, which is combining a RAGE pathway inhibitor, which is one of the pathways that is associated with radiation resistance. There's an oral drug that is available that we are going to combine combined with radiation. We just got the funding approved on Friday, so that's very novel. And it's going to be, the protocol is going to be finished probably this weekend, and we'll be going to the FDA for an IND submission. So that's will be kind of one of the newest things coming down the pipeline. That will be for all patients, and actually breast cancer patients will be included in that, given that they have a high incidence of actually having a RAGE pathway alteration.
How exciting. You guys are in the midst of incredible things coming our way, especially for our communities and those obviously suffering from cancer. Any final thoughts, Dr. Mahtani, before we conclude?
Well, I would just say that I think from a systemic therapy standpoint, the era of precision medicine is upon us. And I think that it's a very exciting time for patients, because we're, as we discussed earlier, for brain metastases patients, starting to look at the genomic alterations in those tumors. But even for patients without brain metastases, we're starting to realize that there are unique mutations that can be targeted, and some of them may not even be with drugs that are approved for breast cancer. It's starting to become kind of tumor agnostic, I would say. And that's something that I think I'm very excited about as we go forward.
And we are so fortunate to have you both in our team of experts at Miami Cancer Institute. Thank you so very much for everything that you do on a daily basis for our patients, and especially those that are suffering from these late conditions. And we're at the top of the hour. As a consideration to you and to our audience, I would like to thank you both on behalf of the entire team at Baptist Health International, to you, Dr. Kotecha, and of course you, Dr. Mahtani, for your time and your phenomenal presentations, and to all of you for participating and attending today's lecture. If you have additional questions about today's presentation, please feel free to email them to Baptist Health International at BHIWebinars@baptisthealth.net. Let me repeat that. It's BHIWebinars@baptisthealth.net. We will make sure to forward those to Dr. Kotecha and Dr. Mahtani for their answer. We look forward to seeing you at our next oncology lecture series, scheduled for October 5th, 2022. In the meantime, thank you so much for your attendance, and have a phenomenal afternoon. We'll see you soon. Thank you both, doctors.
Thank you. Thanks for having us.
Thank you.